Welcome to AETCM. Today we're going to discuss a case about one 50-year-old female who was brought to our ER with complaints of abdominal pain, nausea, and vomiting for past 1 day.
Okay.
Multiple episodes of vomiting was there. Sir.
Okay.
So, shall we begin, sir?
Nice.
So, in initial 10 seconds, patient was conscious, oriented, and was obeying to command. And in coming to the primary survey, the airway was patent and there was no pooling or secretion and there was no abnormal sounds. And she was able to talk normally, complete one full sentence. In coming to the breathing, but the main thing was the respiratory was 22 per minute.
Okay.
And saturation was 98% maintained in the room.
Okay.
In coming to the circulation, but good peripheral pressures were palpable with a pulse rate of 120 per there. So tachycardia was noted and BP was on normal range, 120 or 70 mmHg. Disability wise, GC score was full and pupil was equally bilaterally reactive.
Okay.
And in exposure wise, temperature was normal and she was covered to further to prevent any hypothermia.
Okay.
We further proceeded to a normal survey. In adjunct to the primary survey, we took the GRBS, which came out to 290, sir.
Okay.
And we took an VBG also, in which it was showing that pH was 7.00, sir.
Okay.
And also the PCO2 was in the 12 and bicarb was 2.9, sir.
Okay. Okay.
That was the main findings.
Acidosis,
severe acidosis was there, and lactate was in 18.
Okay.
And glucose on that was 297 with the potassium of 5.5.
Okay.
But in ECG there was no hyperkalemic changes, but only sinus tachycardia was noted with the T inversion in 1 AVL and V4, V5, V6.
Okay.
So at this point of time, patient was having severe acidosis and little bit of tachypnea was noted.
Mm-hmm.
So we were suspecting there was a history of multiple episodes of vomiting also, and GRBS of 290 was noted.
Okay.
So initial we were in a suspicion of possibility of diabetic ketoacidosis, and when the further history we noted she was known case of type 2 diabetes. The main, shall we begin to continue with this?
Yes.
So the complaints was she was a
acidosis. Reasons here it can be due to ketoacidosis. Second thing, it can be lactic acidosis. Third one, creatinine is normal.
Creatinine was elevated.
That also can produce some amount of uremia and acidosis. Okay.
So the main complaints were multiple episode of vomiting, 6 to 10 episode, non-projectile type, and containing food particles, and associated with it she was also complaining of abdominal pain, diffuse abdominal pain.
Okay.
And she was also complaining of some chest discomfort, and also there was no other history of any fever, loose stools, dysuria or decreased urine output, and no history of any LOC, altered sensorium also.
Okay.
And patient was also on evaluation for further checking up. She was complaining of a swelling in front of her neck, which was there for about past 5 years.
5 years. Okay.
Yeah, and which was gradually increasing in the size.
Okay.
And on further questioning the patient, was found to note how she was having palpitation and heat intolerance also.
Okay. Menstrual periods?
Menstrual periods was some irregular sometimes and normally sometimes.
Okay.
But there was no any history of any tremors, weight loss, or bowel movements, and there was no history of any difficulty in swallowing also. Vision was also normal.
Okay. So here main problem is one is thyroid swelling possibly. She has got history of palpitation. Now vomiting is also there, 6 to 10 episodes. That might have created problem. Like she can have severe dehydration, metabolic alkalosis actually. Vomiting produces alkalosis. But here acidosis is there. Okay.
And on further of the same, there was no any allergic history was noted when we are asking, and she was on these medications, sir. Ecosprin she was taking, and Cardi was she was taking.
Cardi was carvedilol.
And losartan and atorvastatin.
Okay.
And Janumet including sitagliptin metformin combination and dapagliflozin and the vitamin B.
Okay. So
past history, coming to the past history, sir, she was known case of type 2 diabetes and history of fibroid uterus, status post hysterectomy.
Okay.
That was done at 10 years back. and she has also a recent history of chest pain and was diagnosed with stress cardiomyopathy.
So what may be the reason for stress cardiomyopathy? What is a common condition which produces stress cardiomyopathy in emergency room?
Panic attack.
Which one?
Panic attack.
Panic attack will not produce stress cardiomyopathy. One is
Sepsis.
sepsis, infection. Okay, then infection is most important. Then if there is tachycardia due to hyperthyroidism, that also sometimes can produce, but that is not called as stress cardiomyopathy. That can also produce dilated cardiomyopathy. Infection is one important reason. Or if you are starting or drugs like adrenaline or adrenaline infusion, sometimes patient can have cardiomyopathy. That is called as tachycardia
the cardiomyopathy.
Okay. Stress cardiomyopathy, mostly it is due to infections, stress like surgeries, trauma, all these things.
And during that time, they had done an echo and all, which was showing normal good LV function.
Okay.
And further, they had done an angiography to further corroborate to their evidence. They done an angiography, which was done 1 day prior to the new admission in the year.
Okay.
So, and it was found to be normal coronaries on that one.
So CAG is done with
CAG one iodinated dye.
iodinated dye. Okay.
So other than that, other symptoms, last meals and events were same as well.
Okay.
There was no significant other things. The main things we had to note was she was taking on dapagliflozin here, and she was had a CAG done 1 day prior to the admission.
Okay.
And so in this condition, we were mostly giving for a differential diagnosis of diabetic ketoacidosis in a euglycemic state because of dapagliflozin.
Okay.
And the further cause for the diabetic ketoacidosis was still not to be known.
Okay.
And we sent with the routine general examination where it was found to have she was having abdominal mild diffuse tenderness was noted.
Okay.
And on examination there was a non-tender mass in front of neck size of 8 to 5 centimeter.
Okay.
Other than that, everything was within normal limits. So we sent for the routine investigation wherein which normal total counts and CRP was kind of in the normal range.
Okay.
And also the creatine was mildly elevated.
Okay, that's almost normal.
And serum ketone was 2+.
2+. Okay.
And other than that, the main factor was we sent for a lab bicarbonate which came out with 2.
Very low.
Very low.
Okay. Okay. That is very low.
And we sent for the cardiac enzyme also, wherein which the TROP-T was 0.84.
That is high, slightly high.
Slightly high.
Okay.
And we sent for the as the swelling was there, thyroid function test was sent.
Okay.
Wherein with the TSH was 0.04 with the free T4 of 4.69 and free T3 of 4.1.
Okay. So what do you think that this is T3, T4 is elevated and TSH is very low and it is completely suppressed. That means what?
Primary hyperthyroidism.
It is hyperthyroidism. Primary or secondary, we don't know. So it is hyperthyroidism. Thyroid gland is producing more of T3, T4 that suppresses the TSH. So hyperthyroidism. Okay. We have to find out what is the reason for hyperthyroidism. Like patient can have viral thyroiditis, patient can have drug-induced thyroiditis, patient can have Hashimoto's thyroiditis, patient can have like toxic multinodular goiter. We don't know what is the reason. Because she is already having a swelling.
So, and on evaluation, the HbA1c was come to be 13.
That is also very high, uncontrolled blood sugar. Okay.
And on further asking the bystanders, it was found to have she was having a normal the thyroid function test about 6 months back when she was checking routinely checking.
Okay.
And on the potassium was on the higher range also. This one also.
Okay.
So here in which we are differential diagnosis was diabetic ketoacidosis, but the cause was not still at known.
Okay.
We were going with multiple chances wherein which the cause may be due to hyperthyroidism.
There is ketoacidosis. There is a ketone body, increased ketone body and acidosis. What is the blood sugar?
Blood sugar is 295.
Is the patient
295?
So is patient received any insulin from outside?
So the patient had received insulin on the prior admission. That is 1 day back during with the for the chest pain wherein was admitted. where she was given insulin
Okay,
during
so
that stay in the hospital.
this is slightly normal blood sugar for a DKA, but even then 250, 295, you can get DKA. That is not an issue. One of the important cause for DKA here is patient is received insulin. He is having DKA, but insulin is already received yesterday. So sugars may be under control because of insulin. Other possibilities, euglycemic hypoglycemia. Euglycemic DKA is common in dapagliflozin. Okay, that is also possible. But to tell you glycemic hypoglycemia, it should be less than 250. So that is not there. So you cannot completely tell it is euglycemic. It is hyperglycemia only. 295 means you are doing in a glucometer. So around 15% error can be there. So it can come down to 15 less. That means 275, or it can go up to 310. Okay. So that range we have to think. Okay. So 15% error can occur in the glucometer, and depending on the squeezing, inadequate technique and all, it can go high or low. Okay. Whatever it is, patient is having hyperglycemia, ketone bodies are positive, and he also has got hyperthyroidism. All these things are there. Even severe vomiting itself can produce ketone bodies positive in the body. Not taking food, the severe vomiting. Okay. What other vitamin deficiency can coexist here if the patient is having altered behavior? Thiamine. Okay. Severe vomiting can produce thiamine deficiency. Okay. That can produce what type of neurological problem? Beriberi. So beriberi also patient can produce altered behavior. Okay. So that also we should consider. Okay, so three problems. One is hyperglycemic ketotic coma. Other one is thyroid storm. Third one is thiamine deficiency induced beriberi. All these things can occur in the same patient. Okay. What is a pancreatic enzyme?
Amylase lipase was in the normal range, 60 and 62.
Okay.
And so here means we actually we didn't know the actual cause for the same the ketotic state.
Okay.
So we were further evaluating for the same only.
Okay.
So we started with the initial management for the ketosis and diabetic hyperglycemia.
Okay.
IV fluids were started.
Okay.
Initial bolus doses were given, and we will check the IVC for further evaluation of how's the IVC patency.
So IV fluid, which IV fluid you want to give here?
IV fluid, NS or crystalloids?
NS is ideal, this one. Okay. Then
we started with the IV insulin also for the correction.
Potassium is normal. So once you start fluids, once the fluid is stabilized, then you can go for insulin. How much insulin you have to start here?
According to the weight, we can start in 0.1
unit per kg. Okay, so that may come around here. That is 70 kg. So 7 units you can start as an infusion. Okay, or you can give bolus and start. Both are equally effective. Okay.
So as the potassium was in the higher range, we never started with the potassium correction for this patient.
Okay. So when you give insulin, what will happen to the potassium?
Potassium, there will be potassium shift. The potassium will go inside.
So already potassium is high, but when we start insulin infusion, potassium may shift inside cells and potassium levels actually come down. So no need to worry. Since the potassium is high, you can directly start the insulin. What insulin you have started?
The human atropine.
Regular insulin. Okay.
And we did the USG abdomen also at that point of time, but she was complaining of abdominal pain with mild diffuse tenderness.
Okay.
And it was showing dilated proximal CBD and cholelithiasis with mild
so
fatigue.
Cholecystitis can be there sometimes. Cholelithiasis is already there. Fat female after 40 years, she has already got cholelithiasis. Sometimes this can go to infection, cholecystitis. Okay, but counts are not very high. Inflammatory markers are low. Okay.
And we did a USG neck also.
Okay.
And bedside USG neck, which was showing thyroid 2 nodule in the bilateral thyroid lobe.
And
multiseptated solid cystic lesion in the left lobe also.
So when there is a multiple solid cystic lesion in the thyroid with elevated T3, T4, we have to always suspect toxic multinodular goiter. Okay, so that we have to suspect. But since the patient is already received a dye, that itself can produce hyperthyroidism. Okay.
So for further evaluation, for the actual cause of the hyperthyroidism, we did a thyroid technician scintigraphy.
Okay, so how do it help in diagnosing thyroid scintigraphy?
Uh, Thyroid scintigraphy, the technician, there will be technician uptake,
Okay,
which will show where how's the thyroid
so
function.
this is
Reduced
your
uptake.
thyroid gland. You are giving technetium. Okay, injecting to that. So if it is only focused on one area, one or two area, what will you suspect?
There will be the cystic lesion, focal lesions.
Increased
Uptake.
uptake indicates always malignancy. Focal. If it is generalized uptake increase, generalized everywhere, then it is mostly thyroiditis. Whereas in viral thyroiditis, uptake is low. That is very important. Uptake is low in viral thyroiditis. Okay. Whereas in immune mediated or destructive, like here what we are seeing is suspected dye injected inflammation. There the uptake may be slightly increased. So what is this one?
Here it was showing as thyroiditis.
Thyroiditis. So it has to be an infective thyroiditis other than viral, or it has to be due to dye induced thyroiditis, or it has to be mediated through immune mediated thyroiditis, not viral thyroiditis. Viral thyroiditis uptake will be generally low. Okay. So what you do?
So thyroiditis, we started with the carbimazole for
Okay.
hyperthyroidism.
Okay.
When
So first of all, you have to see the heart rate. What is heart rate here?
Heart rate was in the tachycardia. Initial heart rate
is very high, 120. So what is the first drug you have to start? Because thyroid hormone can produce tachycardia. That itself can produce stress cardiomyopathy. So you have to control the heart rate. Why? Beta blocker. Which beta blocker is ideal?
Metoprolol.
Ideal beta blocker is propranolol. Ideal. Because it has got it a peripheral action and central action. It can cross the blood-brain barrier. So all the anxiety, fear, tachycardia, everything will be controlled by beta blocker like propranolol. If you are starting other beta blockers, other than the CNS findings, all will be controlled by the other beta. Like if you are starting metoprolol, the anxiety and fear will not be controlled. Other things like sweating may not be controlled. Other peripheral findings all will be controlled. Heart rate can be easily controlled. This patient had only tachycardia, no other finding. So metoprolol will be okay. So you have started metoprolol. Then carbamazole.
Started.
What is the dose of carbamazole you have started?
Started on carbamazole at a multiple dose, like 20 mg we start on morning, 10 and 10 mg at afternoon.
So divided doses you can start. Okay, then you can slowly taper down depending on the thyroid hormone level. You can come down. Okay, no need to continue for a long time. Suppose this is a universal increased uptake. There is no dye injection history is there. Then you have to continue it for many years, like 1 or 2 years you have to continue. Here it's a short-term problem because it's a inflammation. So you can give carbamazole, and once the patient is stabilized, you can taper down the dose and even you can stop it. Okay, then.
Further, we are continuing with the IV insulin and IV fluids along with the carbimazole and the metoprolol for reducing the heart rate.
Okay.
Her serum ketones are now coming down.
Okay.
Still on IV fluids, and also.
So how long you continue insulin, IV insulin?
IV insulin we will continue till our the acidosis resolved and the anion gap is normal, along with the serum ketones and the blood glucose within the normal range.
Okay. Most important thing is one patient has to take oral feeds. Second thing, ketone bodies has to be negative. Once you do that, suppose you are giving insulin infusion like this. Okay, you are giving, suppose now you are giving 2 units per hour. Okay, you are already given 100 units in the last 24 hours. 100 units. Now you are continuing 2 units per hour. Ketone bodies are negative, patient is started taking oral feeds. What do you do now?
We can stop, we can
you see that 100 units we are giving. So how do we split into that?
100 units we can divide it into 3 doses.
Okay, so 30, 30, 30. You can see now you can give 30. Afternoon you can give 30. Night you can give 30. That will come around 100 units. Okay, now when will you give? You give it here. Can you stop the infusion now?
No, we give an initial bolus dose.
Okay.
When wait for about an hour.
Okay.
And follow we stop the.
So around 30 to 60 minutes you wait. Then you stop the insulin infusion. Then continue on 30, 30, 30. So that will be the usual dose. So 100 units we were giving. We have switched to regular insulin 30, 30, 30. Okay. Now after 2 days you are giving, even now you are giving regular insulin. Now you have to switch to long-acting insulin. You are giving around 90 units. How do you switch?
So here 90 yeah, you have to, if you have to switch to the regular insulin, about 70% of the required will be the regular insulin we
So
need.
30 units. So
Totally 90.
So total 90, 70% means 60 units, around 60 units. So you want to give 60 units. Now, how do you split that 60 units in the morning and evening?
So during the morning time there will be more requirement. So we will split the according to that, like 35 or 25.
Okay, or you can give 40. This is the ideal, this one situation, afternoon no need, and 20, or like you told 45 and 15. That will come 60 units, no? 15. Like that you can split. Okay, around 2/3 will be in the morning, and that okay, around 2/3 will be in the morning, and okay, that's okay. Around 2/3 will be in the morning. Okay, that is very important. Okay. So we have discussed about management of DKA and hyperthyroidism. Okay. So both are dangerous in emergency room. If you don't detect this hyperthyroidism, what would happen?
There can go into thyroid
cardiac
storm,
failure.
Cardiac
Most
failure.
important thing is here cardiac failure. Okay. So if you don't treat this patient properly with beta blockers, this patient will go to tachycardia and tachycardia induced cardiac failure. Okay, so that will be the immediate problem. Then again, acidosis can aggravate that problem. Patient is already in severe acidosis. So should we give soda bicarb in this patient?
No, actually there is no recommendation for initial.
So some doctors give soda bicarb, some may not give. Or if you are giving soda bicarb, it's only bridging. So this is the this is the acid. Sorry, okay. Okay, so you are giving beta block. You are giving your patient is this one. If you are giving soda bicarb, that only bridges your therapy. Okay, but it will not change the prognosis of the patient. So some guideline, most of the guidelines does not recommend any soda bicarb in this type of patients, but many doctors give it to transiently improve the situation. To see the values may increase, the values in ABG may increase, but totally patient may not get any benefit because of soda bicarb. If there is a severe acidosis, patient is having cardiac arrest, impending cardiac arrest, your drugs like adrenaline or adrenaline is not working, then you can start soda bicarb. Otherwise, that may not give a edge or other regular treatment. Okay.
Okay, sir.
Thank you.
Thank you.